Hey team, welcome to the MMOA podcast. I'm Macy Bolt, outpatient PT and TA with the older adult division of ICE Physio. One of my biggest frustrations with working in a large healthcare system is the reactive nature of our current sick care model. We are always one step behind and reacting to problems that already exist rather than working to mitigate risk and work more with that primary prevention piece. Today, we are going to get proactive with dementia risk reduction and talk about the updated World Health Organization guidelines that are literally hot off the press as of this month. So, as someone who works with older adults, one of the most common questions I get is, how can I prevent dementia? And this episode is going to truly give you actionable items that you can implement with your patients beyond try some Sudoku and some crosswords. We are going to talk about these guidelines in different buckets, and by the end, you'll have a solid framework that you can work with your patients on starting tomorrow. So the first bucket is reducing harmful substances. This part of the guideline, in my opinion, is the low-hanging fruit because it really is the stuff that you go, duh, of course. It is really well established in healthcare literature that alcohol and tobacco are substances that should be avoided and especially should be avoided in excess. These are conversations we absolutely need to be having with our patients. If we are missing the mark and not counseling on reduction and cessation of alcohol and smoking, we are really doing our patients a disservice. The guidelines are clear that alcohol and smoking have no to cognitive function, and reducing consumption can be associated with decreased dementia risk. It is also worth noting that abstaining from alcohol for 6 to 12 months has the potential to help with recovery of memory, attention, and executive functioning. Regarding smoking, the literature shows that earlier and sustained cessation has the potential to also lower dementia risk. So counseling our patients early and often that quitting can help protect them later in life, and it's never too late to make a change, can be extremely helpful. I think for a lot of our patients, sometimes they feel like, this is a habit I've had forever, why change now? But the research is showing us that there is benefit no matter when you stop. This is our chance to bring some positivity to that often challenging conversation and really share that, by making a lifestyle change now, you could tip the scales in your favor when it comes to dementia risk later on. So while it has less strength of evidence, the other harmful substance that these guidelines touched on was air pollution. We know that a lot is changing with our climate, with, environmental hazards, things like that. And the strength of the evidence for dementia specifically was low. However, the guideline and the remarks that the WHO made were that all people should strive for clean air, and that this is really a public health and a policy issue that we need to be aware of because the air we breathe dictates so much about our health. All right, so that is bucket number 1, which is avoiding harmful substances. So now getting into the second bucket, we are going to talk about managing chronic health conditions and comorbidities. This is really kind of what our medical model is built upon right now, is how can we make sick people less sick? And so we're going to start with obesity and diabetes. This is a really, really hot topic right now in healthcare and in the media. And the WHO guidelines at this time indicate that a lot more research is needed specifically to address GLP-1 use and its connection with cognition, which is absolutely an area that we expect to see more research in the future. At this time, the risk reduction from obesity management in cognition seems to be more from the cardiovascular benefit of things, not necessarily from the weight loss itself. Along that same vein, though, we have diabetes, and we know diabetes is defined as one of the major risk factors in developing dementia. But interestingly, the literature doesn't necessarily show that managing diabetes itself lends itself to reducing dementia risk. Nonetheless, the overall guidance from the WHO is that for folks with diabetes, every effort should be made to manage it through both lifestyle and through pharmaceutical interventions. So then we have hypertension, high blood pressure. Similarly, there is that direct impact on cognitive functioning, and that's really, really well defined in the research. But we know that the strong connection between that risk factor lends itself to really needing to manage those types of conditions. So high blood pressure, cardiac arrhythmias, things like that, all can contribute to dementia risk. And so even though the research doesn't quite strongly support things yet, the WHO's position on this is that we should be managing these things for a person's overall health, not necessarily specifically for their cognition. We also have seen that the guidelines show that early detection and the earlier we can get these things managed can have a protective effect on the long-term outcomes with cognitive health. So we want to be screening for these things early and often. As healthcare providers, we need to be taking people's vitals, because if someone walks into our clinic that we hope to exercise and we are not screening them for something as basic as their blood pressure, we are missing the mark here, and we could be contributing to someone having a later detection of something like hypertension that could be treated. So then moving into dyslipidemia, we know that increased cholesterol levels in the brain are connected with increased stroke risk and the buildup of proteins associated with dementia, like tau proteins and beta amyloid proteins. So again, their position, the WHO's position on this is that more research is needed, but the theorized benefits of managing cholesterol are supported by the WHO recommendation. And that, again, similar to hypertension, similar to diabetes, all people with dyslipidemia should be making lifestyle changes to manage this. The other thing that they touched on here is statins. We have kind of a bias in physical therapy spaces about statins because of some of the negative musculoskeletal side effects that come with this. However, they noted that statins should be used when necessary in order to help mitigate dyslipidemia. They did not, however, recommend statins specifically for the protective effect in cognition. So someone should not be prescribed a statin in order to decrease their dementia risk. They should only be prescribed a statin if their provider feels that that is going to be helpful in them managing their dyslipidemia. But we cannot ignore the lifestyle factor and exercise piece of this, because the research strongly supports that exercise helps dyslipidemia. So that is kind of a big bucket. I think sometimes as providers in the rehab space, we may think that we don't have a lot of impact on those chronic health conditions, but we totally do. Every one of those conditions that I mentioned, diabetes, hypertension, dyslipidemia, obesity, all improve with exercise. We need to be helping people and guiding them as to how they can get more active, get more activity built into their lifestyle so that they can manage those things best. The WHO paper absolutely recommended that lifestyle change and exercise is going to be a protective factor here, and we are the perfect people to be helping guide that. Getting into the third bucket of the recommendations from the WHO is helping people facilitate the use of sensory aids. There is a known link between hearing loss and dementia risk. However, the evidence does need to be continually researched to provide kind of that direct correlation, direct recommendation for the impact that hearing aids specifically have on their contribution to improving cognition. So we know that someone with hearing loss is more likely to have cognitive decline, but what we don't know is whether the use of hearing aids is going to significantly improve that. The WHO's consensus at this time is that hearing aids should be used to treat hearing impairments, but that connection with cognition has yet to be shown directly in the research. The guideline from the World Health Organization at this time is that the pros significantly outweigh the cons when it comes to using hearing aids to manage hearing loss. And even if the benefit is small, the risk of harm with using a hearing aid is basically negligible. So we need to be promoting this for our patients, because even if there can be a small improvement in that sensory input that's going to be valuable to the patient. Interestingly, when it comes to sensory aids, there is so little evidence on visual aids that the WHO was not even willing to make a recommendation on this. My assumption would have been that this would have fallen into kind of the same camp as the hearing loss, but I think because there's so little evidence to show if wearing glasses or corrective lenses impacts dementia risk, they just did not make a recommendation on this at all. That being said, we know as rehab providers, vision is crucial for function, and we should still be screening for this and making recommendations as we see appropriate, even if it is unrelated to their dementia. This also goes for making sure that their glasses are cleaned. Making sure that, they've had a recent eye exam, things like that will help with function, help with balance, help with falls risk, all of those things. And so it may not be directly connected to the dementia, but I do think it is our role to make sure that these things are being managed and cared for. And then finally, the fourth bucket, and frankly, my favorite bucket, is promoting health behaviors. So I want to start with sleep. Currently, because of a lack of evidence, there's no consensus on how much sleep or what quality of sleep folks should be getting to reduce dementia risk. Despite this, sleep is recognized as one of the first symptoms for many folks who have cognitive changes. So it is something we should be aware of and screening for, because we can potentially help folks receive early intervention if we are asking the right questions about sleep. Things like, has your sleep changed recently? Was there an event that made this sleep change, or did it just suddenly happen? Those are all things that we can be screening for, talking with other providers about, and making sure that, should the patient need a sleep study or need a neurology appointment to evaluate cognitive function because sleep is indicating that things are changing, that is absolutely our role. So when it comes to cognitive health, it is really, really well established that lifelong cognitive activity and interventions that support building and maintaining cognitive reserve, which is something that we talk about a lot in our level 1 and level 2 cohorts. We really have to think of that as foundational for cognition across the lifespan. Unfortunately, the evidence base is still lacking to help us determine whether these interventions actually reduce dementia risk and incidence, but most of the RCTs that we have are focusing on repeated cognitive measures, not actually the true incidence of dementia. So what I mean by that is that they are screening for cognition using validated measures over time, but they're not necessarily screening for, did this person develop dementia in this process? So they're looking more at the decline versus the incidence of the disease itself. So that being said, we need to be promoting activities that are novel. We know that new activities help boost cognitive function. The activities need to be cognitively stimulating. They can't be the same boring crossword that someone does every single day. And they need to be relevant to the patient's life to help support building that cognitive reserve. Cognition works just like our physical functioning does, where we need progressive overload. We need a new stimulus in order to see continual change. And that is really, really important to keep in mind. We can't do the same thing and expect more improvement. So this then leads us into social activities. And there is evidence to show a small reduction in dementia risk in folks with higher levels of social engagement. And this led the WHO to support the facilitation of social engagement and activities in order to decrease loneliness and for the potential positive impact it can have on cognitive health and reserve. So not only do we need folks doing new activities and engaging activities, but if they can do them with others, that's even better. Nutrition is another realm where we have some evidence for our patients with cognitive decline. Currently, there is moderate strength evidence for dietary interventions like the Mediterranean diet, the MIND diet, and the DASH diet. All of the evidence is pointing to those having an anti-inflammatory effect. The WHO's position is that we should aim to maintain a healthy, balanced diet and not to focus so much on one specific dietary pattern. So we want to be emphasizing vegetables, legumes, whole grains, healthy fats, and to reduce processed food as much as possible. And then finally, we get to our bread and butter, physical activity. Of all of the risks that the WHO looked at, there were only 2 areas where they made a strong recommendation, and physical activity was one, and tobacco cessation was the other. The evidence is clear and continues to show a beneficial relationship between physical activity and cognitive outcomes. The WHO's recommendation for people with dementia is physical activity 3 to 4 times a week, 30 to 45 minutes per session for greater than 12 weeks for beneficial effects, but the evidence is limited on all the details of type of activity, intensity, duration, etc., specifically related to dementia. Our recommendation is we need to find effortful movement that creates intensity relative to the patient in front of you for the beneficial effects that we know exercise has for our patients and clients. Okay, that was a lot. When it comes down to it, the most important takeaway I want you all to walk away with is that we as rehab and fitness professionals are planted in the perfect place to help guide our patients through this framework, implement these lifestyle changes and behavior changes to truly help make a difference in the lives of our aging clients, families, and friends. So we want to encourage management of chronic health conditions like hypertension, diabetes, obesity, dyslipidemia. We need to encourage healthy diets, cognitively challenging activities, encouraging social participation to decrease loneliness, and of course, promoting physical activity throughout everything we do. We want to support alcohol and tobacco cessation, of course. And for the love of all things good, please tell your patients to put their damn hearing aids in. Thank you so much for joining me today. Head on over to ptonice.com if you are interested in learning more and joining us in an upcoming course. And click on the link below to receive our bi-weekly MMOA digest straight to your email with tons of great actionable clinical pearls.